coming in, and Nuruddin still cannot get in. Okay, let's go. So I'm going to drop this. So this is the same case study that is on the PowerPoint. Remember everything we talked about? So the question now is, looking at this patient, I want us to do it as all of us here in this forum, rather than splitting up in the groups. I know network can probably not allowed. So looking at this case study, a 45-year-old one with Guillain-Barré syndrome, GBS, it can be anything really. But any patient. So somebody with Guillain-Barré syndrome, the presentation is generalized body weakness, has a flicker of muscle activity in the lower limbs, unstable in the trunk, so reduced sitting balance, upper limb muscle strength is 3, needs help with all ADLs, the person is alert, oriented, and cooperative. So how will you plan your maneuvers? So think of in terms of handling techniques, maneuvers, or if you're trying to come up with a plan, and possibly intervention. So what are the maneuvers that will be appropriate for this person, including the piece of equipment and the number of person to be involved? So I want to hear your thoughts, including any rehab ideas. So if you're going to do a rehab for this person, but I will highlight mainly the maneuvers for the moving and handling or therapeutic handling, but you can bring up your intervention. Just to help you, I am really interested in bed-to-bed maneuvers or activity. Okay. For this case, I'm interested in bed-to-bed maneuvers or activity. What will you do? And what are the equipment that you will do? I will allow you time to read the case study, come up with your responses, and then we can have a discussion. So I will give you 5 to 10 minutes to read the case, and then we can now discuss on it. 5 to 10 minutes to read the case. So for those that are joining us now, we are going through this case study. So we are reading through the case. And after reading the case, I will invite us to come and have a conversation around the case. Specifically, I want you to think and come up with ideas around bed-to-bed maneuvers. You can think of treatment for this patient, but I'm more interested in bed-to-bed maneuvers for this patient, including the equipment that you will use and how many people. But you can also think of treatment and share your ideas on it. Okay, I will. Hopefully people have had time to read through and figure it out. So what do people think? What are the possible bed-to-bed maneuvers you will do for the patient, equipment needed? Who wants to open the floor? So the floor is open. We're looking at this case study. Anybody wants to come in and share their thoughts so I can see people typing. You can unmute yourself, but typing is also fine. Bed-to-bed maneuvers. Okay. So Amos have typed start with bed rolling. Yes, Amos, you want to expand?
Yeah, I want to speak on the line of basically since you have generalized what this is,
Yes.
wouldn't be low, that's working in is either research and there that this rolling one side together, using the technique of assisting limb, depending on the strength of the lower limb, whether you help it stabilize the bone and then roll, if you can develop the time and
Okay.
if you be able to roll.
Yeah, it's difficult. I'm finding it difficult to hear you. I guess you are, but I sort of get the general thing just you are mentioning.
Let me try. I have a
Yes.
challenge with my area. Not really
Yeah.
correct.
Okay. Thank you. So yeah, bed-to-bed maneuvers. Thank you, Amos. Bed rolling, sitting retraining. Yep, these are good idea. Anyone has any further thoughts on this? Okay. So as generally speaking, of course, we talk about positioning. Um, Positioning, if in terms of treatment, you can talk about your positioning because the patient will be in bed for a long time to prevent pressure source and optimize their function. Uh, in bed, you can use a lot of things, pillows. You can use wedges or cushion to support the pressure point. And I think earlier on somebody talked about positioning them every 2 hourly. But we discussed about the processes involved in positioning them 2 hourly. So it's yes, positioning them 2 hourly is good practice, but how do you go about positioning them 2 hourly? So it has the emphasis today. Think of the processes involved, either you, the nurses, the assistants, are they doing the right technique so that they will not hurt themselves and the patient? There are equipments that will help. In some climes, we have what we call the pressure relieving mattresses. So even if you will be lying down, apart from positioning or turning, there are usually pressure relieving mattresses, pneumatic pressure, whereby they inflate themselves and they deflate themselves just so that they reduce the risk of having pressure source. And the number of people that will be doing the positioning certainly depends on the patient's weight and stability, or you can think of 1 to 2 people if you are able to do it. But looking at this case, I think the patient has some ability to do the positioning we talked about. If he has an upper limb strength, he can certainly move in terms of transfers. They can move from we can try to transfer him from bed to chair with a hoist, with equipment, and possibly without the equipment. But yes, positioning, transfers. Once he's in sitting position, we can think of sitting balance as mentioned by Amos to improve their trunk control. And then all other things that we can think of. But specifically from bed maneuvers, moving across the bed with potential for transfers to the table. Slide sheets is the equipment for the transfers, rolling using the patient's effort. Sitting and repositioning posture, we described that earlier. Moving from lying to supine at the sitting at the edge of the bed, we described that earlier as well. So the same case, but this time around, the person now has now progressed to, the patient has progressed to, with rehabilitation, as has gained some independence in sitting, but still has some weakness in the lower limb, unable to independently support weight bearing in standing. So that's the second case. I will put it in the chat box. I want you to read through and let me know what you think. Oh, so the second case is this. So for this one, I'm more interested in the sit-to-sit maneuvers, but of course we can talk about the standing. Sit-to-sit maneuvers, but of course we can talk about the standing. So yep, I will probably invite questions around in the next 3 minutes or so by 4:30. So 3 minutes to go through it. This is the case for those that are using the real-time chat function. Okay, Jennifer, welcome on board. You missed the first case. So while people are talking about, so with the first case we said is a patient who, GBS patient, a bit of weakness, some muscles upper limb, some muscles lower limb, and I think the idea is transfers. What will you do in this patient? I said I'm more interested in bed-to-bed maneuvers. So for this patient, we said positioning is the first point, but how do you go about positioning? People talk about 2-hourly position to prevent pressure source, using pillows, bed wedges to help with the patient. But apart from your positioning, it's important to consider how you do it properly. And apart from moving the patients from side to side, we can use our slide sheets, we can use the patient's effort. Sitting up at the edge of the bed, you can use sitting balance exercises for the patient if he's sitting at the edge of the bed. So from bed exercises to sitting at the edge of the bed to balance exercises. And at different stages, it's about the process of how you arrived at there. Earlier on, we discussed about transferring patients from lying to sitting at the edge of the bed. So referring to everything we talked is what will help you to reposition the patient from lying to sitting at the edge of the bed. And if they are sitting at the edge of the bed, that's when you do your sitting balance. So now let's assume that the patient has progressed. This time around, we are interested in sit-to-sit maneuvers, but other interventions that you will do for a patient who has progressed and gets some independence. Can I invite people? What are your thoughts? What will you do for this patient? What are maneuvers you will do and what equipment you will be using? Anybody has any thoughts? Just to let you know, there are two people also. I think they are Dr. Musa Umar and Nuruddin. I think I tried to admit you, but I'm not sure why. It's saying action failed. So you want to probably log out and log in again. So what are people's thoughts on this patient? Patient B, case B. Yes, you can unmute yourself or you can type in the chat function. Yes, transfers. Yeah, good. Okay, thank you, Jennifer. So bed to sit in. So in terms of the sit-to-sit maneuvers, we discussed that, and earlier on, people talk about handling belt. We can certainly use handling belt with or with one or two people. Sliding board, people talk about sliding board. So these are example of cases where we can use sliding board to transfer patient from one seat surface or to the other. What I will also emphasize is discouraging us to use our own muscular strength, discouraging our therapists to pull the patient to try to encourage the patient to do it, trying to encourage the therapist to allow the patient to do it, our assistant to allow the patient to do it. The nurses, if we are invited, let's highlight to them the patient's ability to do it. Apart from the transfer bit, if you are standing them, supported standing, we talked about the standing. We can use the sit to stand practice that we described earlier in terms of standing the patient. And from there, we can progress to get training. Yes, we can use Sarah Steady Vera. Absolutely, yes. You can use Sarah Steady to help the patient to stand. Since you have a bit of weakness, let's see what this case. Yes, we can use Sarah Steady to help the patient. So it has progressed some independent sitting. Yes, unable to stand in weight bearing. Yes, Sarah Steady will be a good option as well. Return, it will be another option of all those transfers equipment to help the patient. Now, this is the last of the three cases that I want us to look at. The last one is the patient has progressed further. I'm going to put it in the chat. So the patient has progressed for that to be progress further and able to stand with minimal assistance of one person, but struggles with increased effort of sitting to standing. So transiting from that sitting to standing position. In standing, his walking is unpredictable and he needs reassurance and some assistance on the stairs. What are the maneuvers will be appropriate for this person, including equipment and the number of people needed? So what are the maneuvers that will be appropriate for this person, including the equipment and the number of? And I really like a suggestion from this case before we move on. So what do you think in terms of everything we discussed? So only focusing on what we've discussed today, what do you think will you apply for this patient, including equipment, transfer practice, and how you can integrate it into your rehab ideas? Only the things from the start to this point. What do you think will be appropriate for this patient? So allow 2 more minutes for you guys to go through the text. Oh yeah, I think 2 to 4 minutes. So maybe by 3:30. I'll Any ideas while others are going through? If you finished, any thoughts on what do you think you will do in terms of maneuvers and that you will use for this patient? Okay, thank you, Vera. Yes, since the walking is unpredictable, assess the environment for risks. Yes, you assess the environment for risks. Absolutely, yes. But staying on the walking. If I'm walking this type of patients, I will start with parallel bars. We all have, well, most of us have parallel bars for safety because of that unpredictability nature of it. So I will start by walking the patient in parallel bars, but also I will assess the risks and everything. That's talking about walking in particular. Then I'll progress the patient to walking in the frame or walking frame or rollator frame. Then I'll reduce the amount of support and use verbal reassurance or physical support as needed. And the equipment is that. But before walking, if we looked at the patient, we can talk about their sit to stand. So they struggle. So I will do a lot of sit to stand practice for the patient because they struggle. I will do a lot of sit to stand practice for the patients because they struggle. So there will be a lot of sit to stand to practice at various heights. Earlier on, we talked about the sit to stand broadly. In this patient, I will change the height of the bed or where they are sitting to engage their muscles. So I will start from the higher position, and as the patient progresses, I will lower the height of the object or the bed to increase the difficulty of the sit to stand. Hopefully, with time, they will be able to get that. And then the walking, yes, and yes, you follow the assessment and coordination, yes, for this patient. Um, and balance and endurance to build their stamina. So balance, yes. And with balance, you can start with static balance. That is what we call static balance. And you progress to dynamic balance, which is more difficult for this patient to improve their balance. You can do weight shift just to enable them. So moving from side to side, because when you are preparing them for that walking or gait, you want to, in parallel, but they can do weight shift from side to side. Stepping drills to be able to negotiate stairs. Um, all this external perturbation, you can add it to the patient. Thank you. Any sort of question so far? Before we move on, any sort of question on anything we've talked since morning till this point? Any questions so far? Okay, if there's no question, in the morning we've been up to this point, we've been talking about therapeutic handling, and we looked at how you can access risks dynamically, so on the spot. But also we say there are paperworks. Assessing risks on the spot to minimize the injury to yourself as well as to your patient. But as an organization, as a hospital, you can, it's not only for your own benefit, but I guess your colleagues also can benefit from your experience. And this is where talking about protocols for therapeutic handling. Protocols for therapeutic handling. If there is a takeaway for you, if you want to have a takeaway and go and think about it, is these protocols for therapeutic handling is a paper check-based exercises that you can do and you can implement it in your own practice. And we're going to run through one of the protocols. I'm going to do it, one of them together with you. And the idea is you will help me do the other protocol for therapeutic handling. Now, this is just a form information that you can search for the clinicians or those that are helping you. But that doesn't take away the dynamic one that you will be doing daily in your own practice. So the first one is if the tax for the patient, now it depends on the tax. So what is the tax for the patient? If the tax for the patient is to transfer from supine to sitting with assistance or without assistance, transferred from supine to sitting. So what is the tax for the patient to transfer from supine to sitting? So this is a document you can create like a checklist or try to do it for your service if you have the time. Then the next bit we need to think about is the patient ability. So what is the patient can be able to do? So we probably said patient is able to cooperate from this protocol, and patient is able to actively involved in transition from supine to lying position. Patient is able to cooperate and patient is able to actively involved. This is different from your case notes where you write all the muscle strength, but by all means you can decide to write all those muscle strengths, level of muscle strength, balance, using the back balance scales and things like that. But when you are communicating with the wider members of the MDT team, it might not make sense for them in terms of the terminologies and the nuances you use in your practice. So you can modify it for the wider team or you can use it for your own service. And what is the clinical reasoning behind it? So how do you arrive at this? So what informed your judgment or decision about this patient? So one is you want to encourage this patient to bear weight, muscles recruitment. You want to encourage the patients to bear weight. You want to encourage them to recruit their own muscles whilst they are transferring. And all the benefits, so we know patients lying down on bed, they tend to deteriorate. The orientation, you want to increase their vestibular orientation, reduce postural hypotension. So all those things you can add them as part of your clinical reasoning while you want to encourage these particular transfers. And second, prevent secondary complications. You want to also motivate the patient. So transferring rather than patients lying down, but transferring them to sitting position will also reduce complications. Then the next bit is what alternatives or what I would say equipment are there to support you in carrying out that function. So it's good to have those ideas. It's good to have the things that you want to do, but what is those activities? So this is an example of handling protocols that you can find in other climes. So the question is, what are those alternatives or equipment that will help you to carry out those transfers. We've already discussed transferring patients from supine to sideline. And equipment, for example, that we can think of, we said is the slide sheets. These are excellent example of equipment that can help us to carry out transfers. But we don't have to have slide sheets. We say we can use bed levers or bed rails. If we don't have the bed levers, we can use the rails of the patient to help us transferring from supine to sideline. We talked about the patient turning using their upper arm muscles to pull themselves. We talked about the patient bending their opposite leg to make sure that it gives them that advantage to push through the bed. If you are assisting the patient, we talked about you positioning your hands on the pelvic and the shoulder girdle to roll the patient to the side. So these are all examples of equipment or alternative that will help you. But if the other question that probably needs to address, which has been the emphasis today, is what is your position? What is the position that the patient will assume? Or what are the processes that the patient will follow through? What are the processes that you as a therapist will follow through? And that is including your positioning. Documenting this will enable, if you are providing a care within the setting, will enable whoever comes to see those patients will be able to follow through whatever you want to do. So the importance of having a protocol like this is we don't necessarily, when somebody comes in, they will understand that this assessment has been done. This is the ability of the patient, and then you just followed the instruction through. The main aim is to enable the patients to be actively involved in that transitioning patient process from the supine line to the sideline. We talked about how you position your patients and your role as a therapist. It depends if it's two-man maneuver or it's one-man maneuver. If it is two-man, one will stand each at the opposite side, but it's important that both of you communicate. So all those things you need to document in your protocol. And then the last one is the hazard/risks that needs to be identified when you are moving that patient, the hazard/risks that needs to be identified when you are moving that patient. What are the hazards? What are the risks involved when you are moving that patient? Both to yourself as well as to the patient, both to yourself and as well as to the patient. Patient might be fatigued in your movement, just to highlight, and sometimes they are understanding. They may not understand what you want them to do. So it's all those things that you need to highlight. Expected changes in their muscle tone or movements. There are different conditions that we come across in our daily rehab. Will our movement trigger changes in their in their muscle tone? Changes in their medical status. We talked about that earlier on. Changes in their medical status. You need to check with the nurses, highlight those things if you think it will affect the patient. The limb, when you ask the patient to move their limb away from the body, sometimes it can get trapped. Or maybe if you didn't ask them, if you didn't ask them to move the hands away from their body, when they are rolling to one side, their hand can get trapped or their body can fall on one of their hands and it will get trapped. Or when they are rolling and then coming back, it can get trapped beside on the side of the bed. If you're asking them to push through the lower limb, and I think I've made emphasis of that throughout the day, is the question of what pathologies do they have on that particular lower limb that will prevent them to push through in the bed? So we need to think about that as well to prevent that or to correct that. If you are unable to raise the bed, I appreciate that in our settings sometimes is a luxury to think of moving the beds up and down and those kind of things. What are the options? We talked about you bending your leg downward or upward, trying to minimize the risks. Instead of bending from your waist, you try to use your lower limbs to bend. So these are check boxes, okay, that you can document if you are doing a protocol within your setting, and by all means, yes, you can do that. However, that doesn't take away the tile rapid assessment that you will do on a day-to-day basis. But this is a good document for conversation and communication within the therapy team as per standard practice. Now, I want you also to, let's see, to look at we're going to work on through the next two cases. I'm going to share also on the platform. So let's say the transferred using the slide board, okay? Let's say the patient, so this time around, the task is patient transferred using the slide board. Because I'm mindful, I designed this as a group activity, but I'm not sure if we split into groups. We almost 43, have less than 1 hour. And I'm mindful of the network. Probably we'll do it as a class activity, just so that everybody is fully on board. So let's say our task is, and I will hand it over to you, is the task in this situation. So let's say these are the things that we need to checklist as a protocol that we need to come up with in our clinic. Let's say this is your clinic. If you have a patient, the task is transferred using slide board with 2 people. And the patient ability is, the next one is the patient ability. So what is the task is for the patients to transfer using slide board using 2 people. Patient ability, which is our load that we need to figure it out. The patient is able to sit on the bed, on the edge of the bed or the plinth, whichever one it is that you have in your clinic, with minimal assistance of one. And the patient is able to flex forward in the trunk, and their feet can be placed on the floor. One arm can be placed in the direction of the movement, so their feet can be placed on the floor. The experience is we want to enable them to get experience in their movement, be it, let's say, spinal cord injury, trying to promote their independence, or not trying to promote their independence. But if they are not spinal cord injury, but just trying to also promote their independence. So patient positioning. Earlier on, we talked about patient positioning. So one is we use the slide board. But my question now is, so before we come about the positioning and everything, apart from the slide board for a patient that has good has some good sitting balance, they sort of can bear weight. What other equipment can you use to facilitate the transfer of this patient? From everything we've discussed or your experience. So apart from slide board, if you are asked to transfer this patient, what other processes or equipment? Let's strictly talk about equipment. What other equipment can you use to help transfer this patient? The floor is open. And I'll put this at the WhatsApp group. Maybe I'll put it now so that people can try to put it as well. So what other alternatives? So somebody doing the slide board transfers, not a spinal cord injury patient, but just doing a slide board transfer. So instead of slide board transfers, what other alternatives can we think of for the patient? Any ideas? As we are wrapping up, I just want to integrate everything we've discussed today. Anybody wants to come forward? What sort of other activities? Any idea that you can do this patient? So slide board transfers, any equipment from everything we discussed today. We talked about earlier on, I'm not sure if people can remember, we talked about return. We talked about you can use TheraSteady. All these are pieces of equipment that potentially you can use as an alternative to slide board. But also depending on the ability of the patient, you can use your manual strength. And in terms of the patient positioning, we discussed that earlier. In terms of if you are using a slide board, it's important you consider the direction of travel. So you reposition the patient's feet in the direction of the travel. And your role is to facilitate the patient in the direction of travel. Positioning wise, if you are doing one or two people, if you're doing one person, you are in front of the patient. If you have the second pair of person, you can use the other person can stand behind and sort of support the transitioning into the direction of travel. That's if you're using slide board. If you are not using slide board, if you are using return, that's the red equipment that I showed earlier. The same positioning of feet of the patient, shoulder width apart. Encourage them to take their legs slightly behind the body. The seats they are sitting down. Think of their nose over toes. Ask them to tilt their body slightly forward to give them that advantage. And they reach, usually there is a parallel bar in front. They reach for that bar and pull themselves up. So that's transferring from, and then that will transferring from that sitting position to the standing. And then they can support themselves. You can use the TheraSteady, whereby they can lift themselves up and then you can put back the sitting rest of the TheraSteady. And the hazard or risks, it depends. So we'll look at it from the perspective of the equipment wise. What you check the equipment for any worn out, the tires, the brakes. You check the equipment. If you're using slide board, you make sure that it's still in good use. If you're using these return, some of them with the belt, you need to make sure that the belt there is no cut or signs of cut whereby it exposes the risk of the sling snapping whilst your patient is being supported. So that's that as an example of the things that we can do as a team. Okay, so it documents about you can think of those documents, everything we've discussed, but you can think of a document around group activity protocol. If it's something you want to develop within your clinics, these are some of the checklists you can do. One is identify the tasks that you want the patient to be doing or the patient relatives to be doing, or your assistant or clinicians. I'm pleased earlier on, I think within the group, some people mentioned about especially the examples with the hoist that has been used. And then the next one is, what is the reasoning behind it? From your notes are your assessment, subjective and objective assessment. And then you identify the patient positioning, therapist role, therapist position, modification, and hazards. I have uploaded the documents which you can populate in the WhatsApp group, and you can discuss. You can use that, modify that, and use it for your own practice. Is there any questions so far? I hope people are not sleeping in the call. I know it's a long day. 5 o'clock now in Nigeria. We are almost there.
No, sir, we're not sleeping.
Okay. All right. Thank you. At least it's reassuring. So things to consider: safety first. When you're doing handling, safety first. I believe all of us, in the beginning, we talked about safety. Safety first. Always think of safety first. Okay. Ensure that both the patient and the therapist are okay. Sort of protect both the patient and the therapist. Proper body mechanics and risk assessment. So think of proper body mechanics and risk assessments. And body mechanics, let me ask, from the session discussion we had earlier, when we say proper body mechanics, what do we mean by that? If anybody can remember what we discussed in the morning. When we say proper body mechanics, what do we
So
mean
the
by that?
center of gravity, base of support, line of gravity.
Okay, that's good. But in terms of you as a therapist, how do you align your body? What do we say about your spine when you are moving?
Okay, try not to like put so much weight on yourself as a therapist,
Okay, that's good.
and using your more like pushing your weight through like your knees, using your muscle groups, and not putting your weight on your spine, sir.
Good. So yes, we're talking about, I think Vera also, correct posture, neutral spinal posture. That is good body mechanics. And when you are moving, push from your big group muscles, the lower limb muscles. When you are moving, avoid loading your spine. Proper body mechanics means that you are using a short lever, not a long lever, bringing the object as close as possible to your body. That is proper body mechanics for you as a therapist. For the patient, proper body mechanics is displacing, depends on what you want to achieve. If you want stability, make sure that the line of gravity for the patient falls within the base of support. If you want stability for the patient, make sure that you lower the distance between the center of gravity and where the line of gravity falls. The lower it is, the better, more stable the patient is. Well, if you want to promote and if you want to challenge the patient, so another thing that you can use is the longer the farther the line of gravity it is from the base of support, you can use it for rehabilitation. The more the patient needs to engage their muscles. So if you are thinking of rehabilitation, the more you displace the center of gravity outside the base of support, the patient has to engage their muscles, uh, in order to counteract that force. So if you, for example, in standing, we tend to ask the patient to perturbation shift forward and backward or sideways, or trying to nudge your patient. So the ability to return themselves back, it's another way to rehab them by displacing their center of gravity outside of the base of support. It enables them to engage on their postural muscles. It recruits their postural muscles. You can use that as a rehabilitation technique by just displacing your patients, simply by just nudging them from side to side, forward and backward. But also, you can, in terms of if you are thinking of proper techniques, it's about creating that stability for them. Risk assessment, we talked about risk assessment. The summary of risk assessment is: one, think of the tasks, whether you can do it, the weight, the kg. Think of the individual capability, which we all appreciate. People are of different morphology. You might not be able to do it. Think of the load, the patient you are moving. Will you be able to move the patient? How physical as well as cognitive function of the patient. Think of the equipment that will help you to move it. Think of the environment at which you are moving the patient. We don't necessarily decide the environment unless if you are a big boss in your setting or a private setting where you can change the environment for the patient. And yes, if you happen to be at the position where you decide your rehabilitation settings, so when they are building new rehabilitation centers, they will come to you for information, expert advice, or patient home. So environment wise, think of your setting well lit, enough lighting. Think of the floor settings, think of the pathway where patient will go in, all those things in the risk assessment. And what is your therapeutic intent? The next one, so apart from safety, is the next one is the intention. Are you trying to recruit the muscles, then displace the patient? Are you trying to create stability for the patient, then keep the center of gravity within the base of support? So what is the intention of your movement? Preferably, in your treatment, every movement should be purposeful to improve either balance, strength, muscle control. Earlier on, we talked about if you are standing a patient, we said a patient that is in standing position, the agreement, the consensus at that time is muscles grade 3, which I agreed. However, even if patient doesn't have a muscle grade 3, we can think of improving their muscle control around the knee. Yes, we can use back slap. Yes, we can use orthosis around the knee. But sometimes think of how you can encourage the muscles to act and function on their own. Using the back slap and orthosis might take away the ability of the knees. If it is working, absolutely yes. But in your rehabilitation, when you want to improve the strength around or the muscle control around the knee, it might be you might alter the height of the bed, increase the patient's height, and then all they need to do is with your support, they need to come forward and back and try to recruit that knee muscles in that supported environment. And that will help more in recruitment of the muscles around the knee. And when they want to walk, you can put back their orthosis, back slap, and everything. But personally, I feel I will not over encourage. So if a patient is coming to my clinic, yes, they will have the back slap, especially if it is weakness, not only pains. If it is weakness, I will, as much as possible during my 30 minutes, 45 minutes, 1 hour, engage with those muscles rather than relying on assistive devices. They are good, they are excellent, but their place is to promote mobility function. But whilst with me, I will improve the strength, muscle control by trying to see how I can wean the patient off those back slaps. So that will be example of an intention. So what is the intention? Always think of what will you achieve, and the intention has to be progressive. Always think of pushing your patient from one to the point at which they are to the point that they need to be. If they achieve this, move to the next bit. Avoid passive lifting. Avoid passive lifting. Throughout today, we talked about encouraging active participation of the patient. You as the therapist are suitably positioned to lead the charge on avoiding passive lifting. If you've seen your assistants dragging, pulling the patient, you need to train them or educate them on the need to encourage the patient to engage in their muscles. And that will be part of your rehab. We talked about, so in your rehab, there is what we call home exercise program, what exercise program. So the example of a patient I gave you, so I told you I have a patient who used a Sarah study. And then my first few assessment is to enable the patient to roll from side to side. Now, because I am confident, so before my coming into the patient's life or before I'm invited, the patient has carers, two carers who help the patient rolling from one side, just the same way I described, and rolling to the other side. And the patient just lie down, fold their hands or lie down, and then allow the carers to roll them. But looking at my own, so that is handling, that is manual handling. That's what the carers are doing, and absolutely nothing wrong with that. But when I came in, I saw the opportunity for therapeutic handling. Once I have done that with the patient, I noticed that the patient can do that with a bit of some support. So the trick that I did for the patient is simply by asking the patient the same thing I described today, turning to the side of the direction of the travel, using their hands to reach for the bed levers. They already have a bed levers. Bending their opposite leg and pushing through the bed. And I practice a couple of times with the patient. And once I am happy in my session, I feel now I transferred the same practice to the carers. Now I don't necessarily do it in my session. However, whenever the carers or the family or the support staff come to clean the patient in bed because the patient is bedbound or support the patient, they don't use their hands to pull the patient from side to side. They only give the patient a verbal cue by carrying the patient, the same talking through with the patient in terms of moving themselves to one side, and then they will finish cleaning the patient, and then the patient will move to the other side. And if they want to use slide sheets, the patient will also use their hands and move to the patient to the one side and move to the other one, even without the patient getting out of bed. That has already improved the independency of the patient by them trying to do things for themselves. And by doing that, they are helping me helping themselves in the rehabilitation journey. So when I come, I will focus on the other thing. That's one of the things that the patient has achieved. So active participation of the patient, always think of what the patient can do by themselves, what the patient can do with their support staff, what the patient can with the support staff in your clinic, what the patient can do with their family members. So for example, also the same patient, what I encourage is clapping, as simple as that, or swinging the arm up and down. So when they are sitting, they can just be clapping their hands and clapping their hands, just to encourage that upper limb, because the patient has muscle atrophy of the lower upper limbs. You can practically almost see their bones. They have reduced muscle strength because they've not been using it, disuse atrophy. So apart from rolling, the rolling is the functional task, but they need to build the muscles of the upper limb. So just by clapping, it's enabling them to improve those upper limb activity. Yeah, facilitation of normal movement, we talked about it. So just moving in a normal movement pattern. I put it in this in quotes because there is nothing really something like normal. Yes, there is a movement pattern, normal movement pattern that we need to encourage. But again, with our patients, sometimes it's near normal, not necessarily normal. Natural movement patterns. So promotes natural movement pattern rather than compensation. So all the movement we described earlier, or I described earlier, these are natural movement patterns that we tend to do every single day without knowing. However, because patients have pathologies, they may tend to compensate for their activity. First line of approach in treatment is try to avoid compensation or try to teach the patient the appropriate way to do things. And that is another concept of neuroplasticity. So because our brain depends on the information we give it to them, if the patient keep on compensatory movements, then it might be that that is the new pattern of movement that the patient will learn in their memory, in their brain. But when we encourage them to do near normal, not necessarily compensatory techniques, it will help them going forward. However, sometimes we have to prioritize function. So we don't have to get a perfect normal movement pattern, but we encourage the patient to move in a functional movement pattern. And functional movement patterns, sometimes they might use compensatory strategies to achieve what the goals that we set out for them. Use tactile simulation, use verbal cues. Use tactile simulation, use verbal cues. So tactile stimulation, I mean, is by using your touch of your hands to encourage gentle touch, stroking the patient. These are all examples of tactile simulation. So just by use tactile simulation, you are not pulling, but you are just doing a gentle stroke for the patient. That is the tactile simulation. Verbal cue is the instruction you give, the motivation you give to the patient. Believe you me, it makes a difference in patients' rehabilitation, which I think most of you probably have seen it in your practice. Tactile simulation of verbal cues. Always focus on the patient-centered. So we talked about patient-centered, patient approach. So think of the patient goal. What do the patient want to achieve? Always structure your activity around the patient goal. So for the patient I was describing, the patient wants to get out of bed, but of course we can't get out of bed on the first day or few days or even few weeks or months. But I break it down to let's first get bed rolling. If the patient can be able to get rolling from side to side, it's an achievement. Then the next bit is we get the patient to sitting at the edge of the bed. It's another achievement with or without equipment. So focused on their goal. And because they want to be able to walk, I've already started incorporating using the Sarah study. So standing, because I know they will need that. So I'm building them only when they are able. We use the Sarah study with a lot of support for them to stand because they cannot stand on their own. And I don't have any standing frame. I don't have any parallel bars. But I'm luckily I have the Sarah study and use them to help them to stand on their own. So just to build that physical ability, as well as to motivate the patient, because lying flat on bed can affect patient motivation, can affect patient self-esteem. And we talked about progressive challenge, trying to build their confidence and their ability as they go along, go forward. You may start from supported movements. Earlier on, somebody asked about neuroplasticity. I said two things. One is practice, two is feedback. Practice means repetition, two is feedback. You might start with supporting the patient, but as the patient progresses, reduce the amount of support we give to the patient. Our therapist, the family members might be supporting the patient, would like to take over all the roles and responsibility of the patient. In our clinics, in our context, local context, I believe we have a lot of loved ones that really loved us, and they don't want, oh, we are sick, and they just want to do everything for us. Therapeutically speaking, probably might not be very helpful. If the patient can do things for themselves, let us encourage the patient to do the things for themselves. We educate, encourage the caregivers to understand that we are doing it for the best interest of the patient. That will include, even if it is trying to reach out for water to drink by themselves. Instead of us giving them, we can put the water just outside, just in front of them, and them trying to reach for the water and drink. That will encourage them to sort of help them in their rehabilitation process. So encourage independence, because that will encourage independence and building confidence. Earlier on, somebody asked me about, can we teach backward chaining to patient or family givers, or should we do it in our own practice? Yes, you can do it on a practice, but the purpose of it is empowering patient, promoting their independence. If a patient fall in their home, you will not be there to support patient to stand up. So it has not served its purpose fully. We don't decide where the patient falls. The patient can fall anywhere. So teaching them the backward chaining, using it at their homes, it's best because they can use it. Teaching them the backward chaining, the family, it is best for them because they take ownership of their rehabilitation. I know it's difficult, different context, but that will be what I will recommend. Yeah. So I've talked a bit more. I want you to think of context settings. I know we've talked a lot, and maybe I will start with this. I will come back to this reflective thought. I will start. I will revise the equipment I talked about. So we talked about equipment. There are lots of transferred aids. If you don't have any, I think it's good, really. If you are in a rehabilitation settings, I think you should advocate trying to get one for your settings. It's good to spend money on all the fancy big mahogany office chair and things like that. But try to also encourage, advocate, and spend money on those equipment that will transform both your practice and that of the quality of care you give to your patient. I really like the example that was given by, I think, is it Zaliha from the Abuja hospital? That's a fantastic example and really good in terms of using that equipment. But I know in probably in other hospitals, even government hospital can have those fantastic. It might be a luxury, but where possible, using those equipment makes a difference in patient's life. There are transverse equipment, there are standing equipment. Maybe I will allow you guys to tell me from the image, just as an exercise before, whilst we are rounding up. Looking at the picture, can you help me, please? Let's look at which one is rotor stand, which one is return, which one is serra steady, which one is rotunda. Who wants to bite first? Who wants to go? Yes, carry on. Is it Enoch? Can you help me name? So which one is which on the equipment on the PowerPoint?
Ma? What day?
So which one do you think is rotor stand? Which one is rotunda? Which one is serra steady? The light blue is serra steady. Okay. So Vera says the light blue is serra steady. Absolutely, yes. Thank you, Vera. Yep. So the light blue is serra steady. So we've ticked it. The light blue is the serra steady, the one close to the list of the names. So we have 3 equipment to go. Sorry that you can't see the PowerPoint. Not sure why, but so yeah, so we've clicked the serra steady. Which one is return? Rotunda and rotaster. Come on, we almost there. Okay. I'm still waiting for you guys. We need to click those equipment and then we can crack on and wrap it up. Yes, the red one is which one? So we have, I'm not sure if people are here. We have Abubakar Abdullahi, we have the Mulawan Adebayo, Adewale, Amaka, Emos, Ayola, Bryony, Christie, Enoch, Idris, Jennifer, Joseph, Ahmad Kabir. Which one is which? So yes, Emos, the red one is Rotunda. Okay. Maybe not. So the red one is Return. The red one is Return. But again, the name is being used interchangeably. The red one is Return. Yes, Vera, the red one is Return. So we have Sarah Steady, we have Return. So Rotunda is yes, Zahilia is typing. Yep, the sky blue. I'm terrible with colors. Yes, the sky blue is Rotunda. Yes, the sky blue is Rotunda. Absolutely yes. So we have one more to go, which automatically will be the rotor stand. Okay. So the rotor stand is the other one that we didn't mention. So the sky blue is Rotunda. The red one is Return. We know the Serra Steady and then the rotor stand. And we all know our slide sheets. There are different types of slide sheets. There is the tubular one. There are the two ones that they flip on each other. So my question back to our reflection is, barriers will always exist. I asked what barriers exist in your practice. But I will say barriers will always exist. But I guess it's thinking of how you can overcome those barriers. How you can overcome those barriers. By using the body mechanics of your patients, by using your own body mechanics to overcome those barriers. Some of those equipment, you don't have to import them. Of course, if you have the money, why not? Example, slide sheet. You can create your own slide sheet by going to a tailor and figuring it out how to do it. An example is because the slide sheet by its concept, they have a slippery part. So all you need to do is find a piece of cloth they are very slippery and very durable because you need to be washing them for infection control. And sew two pieces of cloth and then you have handles on the other side, and then just knit the edges of the slide sheet. And all you need to do when you are moving with your patient is you put one on top of the other. So you move the top part of the slide sheet on top of the lower one, and then you can use it on moving your patients up and down. And that is your slide sheet. If you happen to be the bosses at your place of work, you can use that as part of the budget or to use. If you are doing a private practice, you can use that and have it in your car when you are moving to see your patient as a slide sheet to move, or you can recommend it to the patient and their families to use. But yeah, if you have a luxury of money, you can buy the customized imported one. Not all equipment we can customize them, but think of how you will improve your practice by either using the equipment or using biomechanics to improve the services you deliver. As a final thoughts, while we wrap up, what do people think in terms of what are possible barriers implementing everything we talked about, no matter how brilliant it is? What barriers do people think in implementation of some of those things or all of those things in their own settings? What possible barriers do people think in implementation of some of those things or all of those things in their own settings? Okay, some space. Okay, absolutely, space can be a luxury. So that's where the environment comes in. Knowledge, yeah, knowledge can be another thing. In terms of barriers in the settings, space, knowledge. So what are the things that people think are barriers in terms of your own settings? And I think that will be the greatest takeaway for me. It's not the end. The conversation today, the training today is not the end in itself. It's just the conversation going forward. Different expert therapists here on this platform, people are knowledgeable in their own right. Some people are just starting in their career or maybe in their settings in the particular knowledge in this area. So it all depends on whatever level of expertise or level you are. But think of going forward. What are the barriers that you think? And once you identify that, you can start to think of how you can overcome those barriers. It's not going to be rosy because the implementation of these things sometimes depends, or most of the times, really, the success of it is the law surrounding it, the law surrounding it. So, and if there is no framework in pushing those things, then it will be difficult for you. Already you're on the back foot, but that shouldn't deter you in going forward in identifying how you can make your practice better. Agree with you, Amos. Patient compliance or meeting of the appointment. Yes. Yes, patient compliance. And then I think now probably that maybe not part of handling, but in terms of patient compliance, sometimes it's figuring out how you can meet up with the patient halfway or maybe all the way through what is preventing them, how you can support them. I know it's difficult, but sometimes it's unpacking those things that prevents the patient if once you identify those barriers. So thank you all for the contribution. Like I said in the beginning, if you've attended this training, brilliant. This it's an online training, so I appreciate the difficulty in trying to understand some of the concept I'm trying to explain, especially if it's your first time of listening. Um, it is heavily practical, hands-on activity. I plan to deliver the practical face-to-face training sometimes around March in 2026. The location will be in Gombe. But we will work with the team down in Gombe to see if we can deliver a hybrid sessions whereby if you are not there, you can still see what we are doing physically. But for those that are in Gombe and surroundings, because it's a practical sessions, it might be the question of how much we can take and the time and the space and everything. But once we sort that out with the team down there, we will let you know. So it might be highly restricted in terms of the number of people, but we'll see as time comes on. If for those that probably are interested outside this training, I will recommend usually before the training, there will be the theoretical component, some conversation around here, and that will also be available, maybe in a condensed form, not a whole day session like this, but a conversation around just the knowledge of manual handling before the practical component. That may be happen also around March, also before the face-to-face training. So we'll wrap up. If there is any questions so far before we wrap up today's conversation, are there any questions for me? Any sort of feedback? They said questions or feedback before we wrap up. You're absolutely welcome, Jennifer, unknown user as well. Okay. So I will be wrapping up the session. For now, I will be stopping the recording because there is no new conversation. But I will still stay in the call for the next 5 to 10 minutes